Okay, good afternoon, everyone. Welcome to the rapid fire session. This is where we get all the updates on the subspecialty ERAS sections. So it's going to be a lot of information very quickly. Is Mike Wang here? Because we were going to move him up for neurosurgery. Oh, you're going to be, yeah, okay, yeah, sorry. Mike Yang, yeah, so it's all right. So who's going first? So, no, we've changed the order. That's right. Okay. Sorry, I didn't see that.
Very good.
Thank you.
Great. Well, thank you very much. My name is Michael Yang. I'm a clinical spine fellow in the Department of Neurological Surgery at the University of Miami. It's a pleasure giving you an update on neurosurgery. It is not a coincidence, probably not a coincidence that Dr. Michael Wang asked me to give this talk on his behalf, given that our names are so similar to each other. That may be able to trick you in thinking that I'm actually him. So no conflict of interest and no financial disclosures. So ERAS programs for neurosurgery is relatively early in the stages compared to more mature specialties such as colorectal surgery or orthopedics. But ERAS programs for neurosurgery really split into two different groups, one targeting cranial surgery and the other spinal surgery. And ERAS programs for cranial surgery are typically targeting patients that have intracranial tumors, particularly pituitary adenoma, meningioma, glioblastomas, metastases. However, more recent ERAS programs for cranial surgery has also looked at vascular malformations such as intracranial aneurysms, as well as functional diseases such as hemifacial spasm, trigeminal neuralgia. Whereas for spinal surgery, there's ERAS programs for adult and adolescent scoliosis. There are ERAS programs for degenerative condition in the cervical or thoracolumbar spine, as well as spinal oncology. I'll first quickly focus on the clinical cranial neurosurgery. So this is probably the most comprehensive ERAS guideline for cranial neurosurgery published in 2016 by Hagen et al. And in this guideline, there are 16 different recommendations, 4 in the preoperative, 8 in the perioperative, 4 in the postoperative period. Most of the recommendations are of low level of evidence. There's a lot of ERAS elements in this protocol that is similar to other ERAS programs, but there are some unique concepts for cranial neurosurgery, including the utilization of scalp blocks that's been shown to improve postoperative pain, neuropathic pain, as well as reduce intraoperative stress. Also concepts around MIS cranial surgery, such as using endoscopic skull-based surgery, as well as tubular cranial surgery is becoming more and more popular. So this is a systematic review out of Winnipeg, Canada, looking at the outcomes of some of the ERAS programs in cranial neurosurgery. So in terms of complication length of stay, this systematic review did not reveal any differences in complication rate in those enrolled in ERAS programs versus those that were not. However, ERAS programs were associated with a little shorter length of stay compared to the control group. In terms of readmission rates, there was no difference seen in readmission rates. However, ERAS programs were associated with 25% reduction in cost, as well as improvement in patient satisfaction scores. In summary, ERAS programs for cranial surgery is really relatively in its infancy. Most studies that study ERAS programs for cranial neurosurgery are limited in terms that they only apply a limited number of ERAS elements in their studies. The ERAS Society is planning to create their own consensus statement in the future, probably in the next year or two. For spinal neurosurgery, there's also a lot of literature around the effectiveness of ERAS programs in lumbar and cervical pathologies. In this study out of University of Miami, Dr. Wang showed that in 1 to 3 level lumbar fusion surgery, by implementing an ERAS program, they were able to improve pain control on post-op day 1, reduce opioidization, as well as increase mobilization. In this study, they also showed that there was a 3-day difference in reduction in cost length of stay compared to those in the control arm. And there's also a cost benefit. Hospitals save about $3,400 per procedure, and there was an overall 15% cost reduction. The ERAS Society recently published their consensus statement for perioperative care and lumbar spinal fusion surgery just in January 2021, and there was a total of 21 ERAS components, 28 recommendations, 8 in the preoperative, 8 in the intraoperative, and 5 in the postoperative period. However, most of the recommendations were a low level of evidence, 62% in the preoperative, 37.5% in the intraoperative, and 40% in the postoperative period. So a lot of research that needs to be done, especially around preoperative education and counseling, the efficacy of rehabilitation, preoperative nutritional supplementation, the role of unique surgical techniques such as minimally invasive surgery and the impact on outcomes, goal-directed fluid management, as well as the efficacy or of early postoperative mobilization and physical therapy. So we are currently working on the ERAS interactive audit system for lumbar fusion surgery. This is led by Dr. Bertrand de Bono and Hans de Boer, and myself and Tom Wainwright. We recently just created the first draft of the data collection sheet that we have been sent to NCARE for feedback, and we expect the EIA system for lumbar fusion surgery to be ready in Q2 to Q3 of 2022. Just a plug, this is the ERAS USA Spine website where you can find current events and news associated with spine ERAS. It's really been led by Dr. Ib Hussein. There's also a journal library on this website linking to articles that we feel is relevant in the advancement of spine ERAS. Thank you.
I think you can see the neurosurgery and spine section have had an enormous amount of energy and they're going at a rate of knots, so thank you very much. So next we've got an update from past President Dionysios Vrochidis on hepatobiliary surgery.
Thank you, Mike. I hope everybody's well caffeinated. So I'm going to talk about HPB ERAS. Who is an HPB surgeon here? None. Great, I'm done. All right, fair enough. So yeah, the guidelines for hepatectomy, let's start with hepatectomy. Hepatectomy guidelines were published about 5 years ago. Ever since the publication, we have seen an increase in the publications on ERAS in hepatectomy. For the last year, there were 18 papers out. I chose 5 of those to very briefly discuss. The first one comes from France. It talks about implementation of ERAS in cirrhotic patients. We can see here that the benefits that they are usually procured by an ERAS implementation, they are not procured in cirrhotics. And the reason could be either because the ERAS guidelines do not include items that they are specific to the cirrhotics, or because cirrhotics, they are quite tough to achieve compliance. You see that the best compliance we can get is about 60%. The second paper comes from Korea. It's a qualitative study from HPB surgeons. They had the impressive participation percentage of 82%. We can see that surgeons still, they are very resisting in adopting ERAS principles. Any item in the guidelines, the compliance with that is anywhere between 5 to 20%. Third paper comes from China. It is actually a well-designed prospective randomized trial. It has to do with the association of early oral intake in patients that are undergoing hepatectomy and the correlation between biochemic markers and the symptomatology burden of the patient. Clearly, there is a correlation with all the usual inflammatory markers like IL-6, TNF-A. The fourth paper comes from UK. It's an interesting meta-analysis on preoperative immunonutrition for hepatectomy patients. The 11 papers were included, and there is very clear high-level evidence that immunonutrition confers improvement both in wound infection prevention and in length of stay, with an impressive reduction of 5 days in length of stay. The final paper for hepatectomy has to do with long-term outcomes, oncologic outcomes, specific on colorectal patients. This is a good study with 1,200 patients. They were case matched 600 versus 600 patients approximately. And there is very clear indication that once you have enrolled patients in an ERAS pathway, hepatectomy after colorectal metastasis, you confer significant improvement in both overall and disease-free survival, much like the Gustafson publications about 10 years ago on the colorectal patients. Switching gears, we're going to pancreatectomy. These are the pancreatectomy guidelines. Actually, we have the new version of them that they were published about 1 year ago. I remind everybody that the first pancreatectomy guidelines came out in 2012. I think, Mike, you were involved in those too, correct? Yeah, you were there. So the new guidelines, they have 27 items. 13 items are exactly the same as the previous guidelines. 7 items were somewhat improved. 5 of these items, they were significantly improved, and there were 2 items that they were added. One on prehabilitation, very important component, and the other on minimal invasive pancreatectomies. Pancreatectomy and ERAS, the publications, because of the older guidelines, they were a little bit on the decline. I suspect that with the new version, we will have more papers coming out. Regardless, from last year, that we identify 15 papers, ERAS pancreatectomy. When I include papers in that, all of them, they have compliance. If they do not have compliance, they are not included in the analysis that I'm discussing. Out of the 15 papers, I'm presenting again 5. The first one is a good feasibility paper, multi-center international cohort from centers that they do ERAS for many, many years. They're very experienced, and they have all their results and outcomes in the AIS database. We have seen in this paper that the magic number of 70% of compliance, that it's very well known for colorectal surgery, it applies for pancreatectomies as well. And if you had to do one only item to attack as a center, only one item to improve outcomes after pancreatectomy, after Whipple's procedure, that should be mobilization on day 0. The second paper comes from UK. It's an interesting paper because it changes the focus of the targeted outcomes. Instead of the usual length of stay and readmission rate, it goes to the textbook outcome. Why this is important? Because there are some centers of excellence that they are already doing very well in length of stay, and after implementing ERAS pathways, you cannot really improve this, the number of the length of stay. However, what you can show improvement after ERAS implementation is achievement of textbook outcomes. You can see here that the improvement, the percentage improvement in any textbook outcome that you can choose for a pancreatectomy is about 10 to 15%. The third paper is actually a very interesting clinical question for pancreatectomies from pancreatic surgeons, is association of the early intake, by mouth intake, with chyle leak. And there was a fear that by doing that, we will have an increase in the dreaded complication after Whipple, which is chyle leak. Well, we have shown, we see in this paper that not only we do not have increase in the chyle leak rate, we actually detect the chyle leak faster, which leads to faster treatment, and in the end leads to decrease in the cost. The last 2 papers, they have to do with oncology. The first paper comes from China, and it shows that with the utilization of ERAS pathways, you can achieve RIOT. RIOT is a return in intended oncologic treatment 2 weeks earlier. So instead of 68 days, you decrease that, you restart the chemotherapy or the radiation in 54 days. And perhaps that is why we observe what we observed in the last paper, the improvement in oncologic outcomes for Whipple patients with pancreatic adenocarcinoma in patients that they were enrolled in an ERAS pathway and they were compliant with that. And this is where I stop. Thanks, everybody.
Great, thanks, Dionysus. Catherine Frankel's now going to do the head and neck surgical oncology. Thank you.
Thank you. Good afternoon. I have no conflicts of interest to disclose. I'm going to talk a little bit about our individual ERAS program at the Levine Cancer Institute, because ERAS has not been adopted ubiquitously in the head and neck surgical oncology academia world, and so we're really struggling to define what patients you include and what components of ERAS may have a problem when we apply them to the head and neck surgical oncology group. So to start, all of the patients that we included in our ERAS program were patients who needed reconstruction due to large head and neck soft tissue defects. Their subsites included the mandible, the maxilla, the anterior 2/3 of the tongue, the floor of mouth, buccal mucosa, or people with pharynx defects secondary to a laryngectomy. All of these patients are having a treatment for either primary cancer or an undesired treatment effect that's cancer-related, secondary to radiation or potentially aspiration from a dysfunctional larynx. All of our patients, or almost all of them, have gastrostomy tubes for feeding and tracheostomies, and they're not mechanically ventilated in the immediate postoperative period. We didn't include all free flap cancer subtypes because some of these cancers, like skin cancers, have a less complicated hospital course. So really in our institution, we applied ERAS to the subset of head and neck cancer patients who have who are the most complex, who have the highest complication rate, the highest length of stay, secondary to nutritional, feeding, wound, and airway complications. All of these patients require free flap, which is donor tissue from the leg, forearm, or back, including skin, soft tissue, muscle, with or without bone. And almost all of our patients can walk postoperatively, but there is a subset of patients who have a fibulectomy where their activity is restricted for the first week. This is a multidisciplinary effort because it involves surgical oncologists, plastic surgeons, critical care surgeons because our patients are in the ICU for 2 days, speech and language pathologists, nutritionists, physical and occupational therapists, pre-op inpatient, outpatient nursing staff, anesthesia, and social workers. And the goal, a lot of this is what is our goal in trying to accomplish or implementing ERAS, and one of the main goals is to improve discharge to post-op day 7. We compared 50 patients versus 142 patients, and we were able to basically halve our length of stay so that our median length of stay now meets a target. And so what is a meaningful outcome for implementing ERAS in the head and neck patients? A lot of people have social issues that lead to extended discharges, and so really the median length of stay is much better than the average length of stay because it's less impacted by the outliers. This is our outcomes pre and post ERAS. Even when you look at the average, we decreased our average length of stay by 2 days, and all patients who were ready to leave the ICU were out of the ICU within 24 hours. And we had no changes in our readmission rates. They did not increase. And this is very interesting. We had no impact on the reoperation rate, the readmission rate, but we actually had an increase in complications post-ERAS, probably because we were capturing all of the complications or some of the complications through good documentation. But we attribute this length of stay improvement solely to the improved compliance on the left versus the right through an introduction of ERAS. We noticed that unplanned admissions drove our elevated postoperative length of stays, so we implemented a prehabilitation program for people who had unmet nutritional, social, and pain needs that required an admission preoperatively, and through this, we were able to decrease our postoperative length of stays significantly. And you can see here that compliance was inversely related to our total length of stay. But our overall compliance over time really hasn't changed and is about 60%. Obstacles to optimal compliance for head and neck ERAS programs, some of them are clerical, as people had stated. Some of the requirements are just inapplicable. So tracheostomas, I haven't seen those closed with a suture in a decade. Accuracy and relevance of alcohol and smoking usage preoperatively. So if a head and neck cancer patient is still smoking with an advanced tumor in their mouth, they're not going to tell you how many cigarettes they took 2 weeks before or how much alcohol they drank. Oral fluids, they're not going to drink anything. All of our patients are NPO post-op. They also have challenges with preoperative oral carbohydrates because they're driving to the hospital and they have a lot of pain when eating when they try and in order to do the before 2-hour oral carbohydrate loading. Mobilization on the day after surgery, on the day of surgery. So our patients make it to the ICU about 5 to 8 p.m. Our surgeries are about 6 to 13 hours. Sometimes we've just taken off a significant portion of their face, and so they have had a long day, and they really need to sleep overnight. So they get up at about 5:30. In the morning waits, our patients don't have significant fluid shifts. We're not in a body cavity, and so that may not be applicable either. But we are working on antibiotic prophylaxis timing, delays in tube feed initiation, and patient education and urinary Foley catheter compliance. Flat monitoring, people are doing it, they're just not documenting it. Mobilization, they're not documenting the duration appropriately. Pre-admission patient education was great initially, and when the volume increased, our ability to educate patients decreased. And then time to termination of urinary drainage catheters. Basically, we have a population of men over the age of 60. And so this has been a real issue that we're trying to, as other people are, predict who will fail or develop post-op urinary retention and preempt that. So in conclusion, despite an ERAS compliance rate in our head and neck group of about 60%, we've been able to meet our target length of stay after program implementation without an increase in readmission rates. And our data has equipped us to identify targets for future clinical quality improvements like urinary retention. And then ultimately, we hope to allow this to decrease our complication rates, because in head and neck cancer, the complication rates drive a delay in adjuvant care, which then decreases survival. Thanks.
Thanks, Catherine. Next, we have Greg Golladay, who's very kindly flown in from Virginia just to give this talk, and he's giving the update on orthopedics. Thanks, Greg.
Great. Cheers. Thanks for having me back in New Orleans. So here are my disclosures. None of them are relevant to this talk. What got me here is a desire to do better. Like I think all of us, we want our patients to do better. I also had good mentors like Mike Scott and Steve Cates. The opioid epidemic, I think, drove a lot of this thought process, as did alternative payment models. We're trying to decrease length of stay and cut costs and improve outcomes because it's on our nickel now. And patient selection and optimization have been important to me, and I was fortunate to be included in a group that looked at the surgical technical evidence for quality for hip and knee replacement. So as a quick update, I wanted to review some of the latest literature that has come around since the last time I was here presenting. There was a series of systematic reviews that have been done. This one was published in the Journal of Orthopedic Surgery Research. 15 studies were compiled, and they found an overall lower risk of complications. You can see an odds ratio of 0.7, so about a 30% reduction in complications, lower mortality, and no differences in readmission, which is the point that keeps coming up. If we can get people up and out quicker, are they coming back more? And it appears that with the enhanced recovery protocols, that's not the case. This was a randomized prospective trial out of China in patients undergoing knee replacement, 65 years and older. They had an ERAS pathway versus standard care. And in the ERAS group, there was shorter length of stay, fewer transfusions, and very small differences in early pain scores. So these numbers weren't terribly impressive, but it was a relatively small group of patients and perhaps underpowered to detect differences. This is a level 4 observational study. This was out of Italy. There were 207 patients total, comprising hip and knee cohorts, and compared to historical controls, the patients undergoing an enhanced recovery protocol had a shorter length of stay, higher patient satisfaction, interestingly, as well as a lower need for post-acute care. And I think that's one of the things that we're looking at in our institution to identify what methods that we can use to reduce the need for post-acute care for multiple reasons, including the cost involved. There was another level 4 retrospective cohort study. This is 100 intertrochanteric hip fractures with 50 per group. The patients in the enhanced recovery pathway had shorter length of stay, once again, improved VAS pain scores, less overall opioid use, so opioid-sparing multimodal analgesia did seem to win out, but they also had a lower reoperation rate. They were more likely to be discharged directly to home, and more importantly, perhaps, is that out to 3 months, these patients' outcomes were better. So we're not just talking about short-term and in-house complications or 2-week complications or wound complications that delay adjuvant therapy, as the last speaker noted, but maybe there's a more sustained longitudinal benefit for putting patients in an enhanced recovery protocol. This was another systematic review that I was a part of. We compiled 9 studies with over 7,000 patients or participants. About a third of them were in enhanced recovery protocols and about 2/3 were not. The only finding that we determined from this data was that length of stay was lower in the ERAS pathway patients, but the heterogeneity within the studies and risk of bias from moderate to high limits the strength of the conclusion. So it really raises the question, how can we get better evidence out there in orthopedics? And we wrote an editorial in one of the journals kind of calling for that and kind of trying to raise some awareness there. Here's a relatively recently published, but data that spanned between 2006 and 2016. So over a decade, over 1.5 million hip and knee patients. And what they found was over time, the trends have been that more and more patients are being enrolled into ERAS pathways. And the more elements that are being utilized, the better the outcomes and lower complication rates. The most important 3 variables that this study identified was early mobilization, avoidance of urinary drainage catheters, and use of tranexamic acid. There's one more randomized prospective trial out of China. This was 69 patients. The elements that they considered were preoperative carbohydrate drink, phase tourniquet use, periarticular injection, and TXA. And they had earlier mobilization, shorter length of stay. And again, this is interesting. The outcomes were better out to 12 months. So there may be a longitudinal benefit to doing a good job early. So in conclusion, we have had growth in adoption of enhanced recovery and ERAS principles throughout orthopedics, but I think there's more work to be done to understand which of the measures are most important in the longitudinal effects. Probably patient selection and optimization are the most critical parts. Thank you.
Thanks, Greg. We're now doing a vascular surgery update with Kate McGinnigal. Oh, there you are. I couldn't have the wrong glasses on.
Thank you so much for the invitation, and I know that I'm always the only vascular surgeon in the room. I have no disclosures, but I promise that I'm going to skim over a lot of the very vascular specific information and stick to the highlights here. I would note that usually when a vascular surgeon walks to the operating room unexpectedly, all the anesthesiologists wince and look the other way. And that gives us a little bit of a free pass, if you think about it, because everybody expects vascular patients to do poorly because they're sick, they have existing pain conditions, they're old, they're frail. There's probably going to be blood flying all over the place, and so clearly the outcomes will be bad. But when you've been indoctrinated into ERAS like I have, that means that there's lots of opportunity for improvement and lots of standardization of care. That's a little bit challenging because we're all over the place. We can't just focus on 1 or 2 operations. But for the purposes of today, I'm going to focus on open aortic surgery, whether that's aneurysm repair for aortoiliac occlusive disease. And so this is data from the OVER trial. This was a trial of aneurysm patients who were in general healthier than the average aneurysm patient that gets open surgery today. But I want you to note that in the quote-unquote healthy vascular patients who just have aneurysms and not occlusive disease, still 50% of them were smokers, 50% had coronary disease, and 20% of them had PAD. And we know that compared to matched cohorts of patients undergoing other types of surgeries, patients with aneurysms are 5 times more likely to die within the next 5 years of not aneurysm-related issues. And so there's a big challenge, and when you look in the Vascular Quality Initiative, which is like NISQIP for vascular patients, you can see here, this is in-hospital death after elective open AAA surgery, and there's 875 centers across the United States and Canada that participate in the VQI, and you can see that the dark blue bar is the overall 4% in-hospital death after elective surgery. Clearly, we have a ton of room for standardization and systems improvement, and this really is not acceptable. So, ta-da, here comes the unveiling of what I've been doing for the last 2 years since I saw you in person. The official perioperative care and aortic vascular surgery consensus statement between the Society for Vascular Surgery and the ERAS Society. I've had the joy of working with multiple different surgeons across the United States and Europe, as well as anesthesiologists across Europe and the United States, and APPs, and we have put together open aortic guidelines that span all of the standard ERAS criteria that you're used to seeing. Most of this data was extrapolated, at least in part, because ERAS has not been something that's been widely adopted or accepted in vascular surgery as we've moved more and more away from general surgery and into the endovascular space. But there's a lot of good information that's going to be getting published, hopefully imminently any day now. And, you know, it's got all of the same standard stuff. Sorry, I was supposed to advance the slide when I said that last bit. But I think that, as many of us have talked about today, we really need to focus on what happens when you deviate away from an average, healthy-ish, 50-year-old colorectal patient. And a lot of information can be extrapolated, but there's a lot of things that we need to focus on, like urinary retention in people who are 65 and older and males, or people like spine patients and vascular patients who have pre-existing pain conditions. And certainly the brain health information that we heard yesterday, I felt like was tailored specifically to me and my patient population. And there's a lot of gaps in the literature. As the ERAS and vascular surgery has been evolving, and as we've been writing these guidelines in the last few years, the vascular surgery community is very eager to uptake a lot of these principles. But there's a lot that we don't know, and there's a lot that people are nervous about. They mention that our patients are older and frailer. There's a lot of focus on prehab. None of the prehab trials include vascular patients, and people are worried about elevating blood pressures and rupturing aneurysms, or delaying a revascularization for somebody with occlusive disease who's not really going to be able to walk anyway until you do the operation. How does that play into falls risks and early mobility? And do we really have the support that we need to do early mobility in these patients, and how can we prioritize that? Aspiration risk is a really big one. Vascular surgeons are going to be very slow to adopt the early oral food, but we'll get there. NSAIDs, I think, are really, really scary to vascular surgeons. So far, the literature only shows that pediatric tonsillectomy patients are at risk for bleeding with NSAIDs, and tens of thousands, if not hundreds of thousands, of other patients who have had surgery with NSAIDs have done it safely without bleeding. However, replacing somebody's aorta and being worried about bleeding risk is kind of emotional, and we don't have any data to support what we should be doing around NSAIDs as part of multimodal analgesia. So if you want to work on that, anybody in the room, I would love that specifically. Fluid management is a biggie. Goal-directed fluid therapy is a really challenging, I understand, for the anesthesiologist when you're operating on someone who's got an aortic cross-clamp and heart failure and at risk of kidney injury. And then most of our patients are diabetics, and it's hard to know what to do about carb loading because most of that literature is in non-diabetics. So these are all really big gaps, I think, that apply to my patients, but also many of yours, and I'm very excited to get more vascular surgeons here next year. Thank you.
Next up for the plastic surgery update is Jessica Urban-Sager. Hi, Jessica.
Thank you very much for the opportunity to speak. Lovely to see you all in person again. Well, I have no disclosures. So the tenets applied to plastic surgery, ERAS pathways are the same ones which everyone here is familiar with, and I won't belabor these. Within our specialty, the majority of publications have been on breast reconstruction, as we heard earlier from our colleagues at VCU. There have been a handful of studies on abdominal wall reconstruction and head and neck reconstruction, and even a few on cosmetic surgery. The vast majority of plastic surgery really has not benefited from ERAS pathways. However, many of these patient populations, such as facial trauma, hand, lower extremity, and pressure sores, no doubtably would. And the data is very clear, and it's shown a lot of the same themes that have been elaborated previously, but decreased MMEs, decreased PCAs. Interestingly, it's anesthesia and ERAS meds have been shown to be really synergistic. So this particular study looked at patients having autologous reconstruction, such as deep flaps, et cetera, and paravertebral blocks were more effective when given with ERAS meds than either paravertebral blocks or ERAS meds alone. There's also been a clear demonstration of decreased length of stay and going so far as same-day discharge for implant-based reconstruction. But all this would not be so good if we saw increased complications, reoperation, readmissions. But fortunately, the literature has been clear that really for both implant-based and autologous reconstruction, there's been no increase in complications and no difference in readmission, reoperation, or flap loss, which is very important for us as well as for ENT. There was one reported increase of wound healing problems after free flap breast reconstruction, but that was kind of an outlier and has not been reproduced in other studies. Finally, cost reduction was significant, and this was over $4,000 in multiple different studies, mostly attributed to getting patients out of the ICU and also decreased length of stay. So everyone loves a good controversy right now. These are the current ones, liposomal bupivacaine and gabapentin. So for liposomal bupivacaine, it's controversial, at least for us, because of the cost and potentially the lack of evidence showing benefit. However, within plastic surgery, studies have shown a benefit. And one such study used a national database to analyze breast and abdomen plastic surgery procedures, and again showed decreased length of stay, decreased cost, and lower 30-day readmission rates. And if you look at the cost difference that I've listed, it's way making up for the cost of the liposomal bupivacaine. And then another study looked at immediate breast reconstruction cases, and these patients actually got, some of them got liposomal bupivacaine but got no ERAS meds, and they still showed a reduction in mean length of stay and pain scores that were lower, and you can only imagine had they had ERAS meds, it probably would have been even better. And that's just the data from that paper. So what's the deal with gabapentin? Well, it kind of began to reach a fever pitch in January of 2020 when the FDA issued a black box warning for gabapentin. They warned of serious respiratory suppression and death due to 12 deaths over a 5-year period. Highest risk, as probably most of you all know, with a number of risk factors. And there was less evidence in healthy individuals taking gabapentinoids alone. And they recommended starting at the lowest possible dose. So that was kind of followed like a 1-2 punch by this meta-analysis in anesthesiology. And so after the study came out, we actually received a lot of pressure to remove gabapentinoids from our pathway, and actually some of the other pathways at our institution did remove it. However, before doing that, I kind of wanted to dive more deeply into that paper. And it's a great paper, and there were a lot of trials included. However, very few were actually included plastic surgery patients, and they were also kind of lumped with peripheral vascular or breast surgeries, which are kind of a diverse group. And we administer gabapentinoids before and after surgery, and actually 3/4 of the patients in those trials administered only before, so that's not too relevant for us. And then finally, regional anesthesia was rarely used, only in 9%. And if you remember what I said previously, that those really have been shown to have a synergistic effect in our literature. As far as the results, there was in fact a reduction in the MMEs and less postoperative nausea and vomiting, and greater incidence of dizziness, but not associated with respiratory failure, falls, or delirium. So, and in our literature, both in outpatient surgery, we've showed decreased MMEs and PACU pain scores, and after free flap breast reconstruction has also been shown to a similar degree. In response to these concerns, we kept gabapentin in our pathway. We had no evidence of respiratory suppression. We had a low threshold to admit gabapentin and a high level of vigilance for respiratory suppression. So in conclusion, ERAS is beneficial in plastic surgery. Thank you.
I think I'm with Jessica on that one. If you think just a high level, the FDA, a black box warning for 12 deaths in 5 years, which is regrettable, and yet we have a death every 12 minutes from opioids. When you really look at what's going on, we do need better guidance, don't we? So thanks, Jessica. So the next section is the APP and nursing section, and this is very important for the society. And we're very pleased that Misty Ella is going to give us an update on what we're going to do and try to get the recruitment as well and numbers up in the next year or so. Thanks, Misty.
Hi again. So I'm just going to do rapid fire. Mine's going to be a little bit different, shift a little bit from what everybody else has been presenting. Less about the literature, more about ERAS and having APPs and nurses involved. So what I plan to talk about today is how many of us there are in practice, because I really think it is impactful for you to see the numbers. It's really difficult when you start saying we need people to be involved, and you look at 500,000 people in this country are either a nurse or an APP actively practicing, and then our membership being as low as it is right now, and we've had a drastic decline since 2019, as well as the showing here for this Congress. And so for it to maintain multidisciplinary, I think it's very important that all of us get involved, more involved, and that we get our friends involved. So there's just over 325,000 nurse practitioners in practice. That is per the AANP, and that is as of November 1st of 2021. There are right around 150,000 physician's assistants, that's from the AAPA, and then 6,200 nurse midwives and about 59,000 CRNA or student CRNAs that are actively practicing, and then 3.8 million nurses with active licensure in this country. 84% of those are actively practicing. Now, granted, that doesn't take into account the people that have left the profession or that are on hiatus, from COVID. So roughly 0.002% of APPs, as well as RNs, that are actively practicing and have an active license are involved in organizations like this, which we consider ERAS USA a physician-run and surgeon primarily organization, but they really do take into account what we say. I mean, I'm on the board of directors, I'm the APP chair, and the committee chair, and I can tell you that, whenever I tell them hey, this is ridiculous, or hey, this is great, they do take into account what we think, and I take polls through the committee from the nurses, and I know Jackie does from the nurse committee, and so we want to hear what you think as well as what your colleagues think as well. So roughly 80% of the ERAS items on any given guideline, that's not just HPB, which is what I primarily deal with, but any of the guidelines, if you look at those, 80% of those are directly impacted by your nurses or your APPs on cross service lines. That doesn't matter which one of you. So if you're the only vascular surgeon in the room, Catherine, it doesn't matter, because if you're doing vascular, if you're doing colorectal, if you're doing HPB, gynonc, you still have APPs and nurses that are taking care of your patients and that are actively involved, and so you need to pay attention to what they're telling you. And this demonstrates that it's truly multidisciplinary program and that we'll be more successful the more multidisciplinary we make that. So I think from our perspective, getting more allied health, pharmacy more involved, getting our CRNAs more involved, I'd really like to see more of a showing over the next year or so from those folks. So some specifics. Problem of the Month series, I just wanted to kind of review this and highlight it. So we did it October of 2020 through March of 2021. It was organized by the APP and nurse committees. We did 6 months worth of monthly education where it was all virtually done. Everybody logged in, and we had several topics, anywhere from compliance, education, order sets, glucose control. I really would like to have seen, honestly, more of our physician and surgeon counterparts, because some of this stuff is things that you guys talk about a lot, but these are ways that we impact it, and we can tell you how we can personally impact it. And those are things you can take back to your institution, to your APPs and your nurses, like, hey, these people, get in touch with them, talk to them about how we can improve our compliance or how we can improve our education. How do they develop the order sets? For me, like, we developed standardized documentation, and so I have ERAS notes that, we make sure that all of the items and stuff are in those ERAS notes so that it can be put into discrete data points so that it can automatically be transferred out of the EMR. So the future is, I think that we need to work really hard on communicating with our APPs and our nurses. I think that from a surgeon standpoint, if you make it an expectation, I don't want to say mandate or requirement, but if you make it an expectation from you that they get involved with the organization, then bring them to me. Have them get in touch with me or with Jackie, and we'll be happy to kind of guide them on how they can get involved. I would love to see a lot more involvement across the board, and I think it's important for our physician colleagues as well to have us doing, a national stage and doing presentations and being able to be involved in the programs. That's it.
Thanks, Misty. And please do support your APPs and nurses to try and come to the meeting. We're looking at the board meeting, we were trying to get institutional membership, so you can get 6 of your APPs or nurses to come and be members each year for a discounted price. So look out for that. So next we have Greg Nelson, who's presenting the update on gynecology and obstetrics.
Great.
Thanks, Greg.
Before my time starts, I just want to say how important it is, you can start anyway, nurses are for ERAS. One of the highlights that I've read in the literature from Martin Hubner's group is that they showed that increased ERAS compliance is actually associated with decreasing nurse workload, so something important to remember. Okay, so I'm really happy to give this update for you today. This is going to be truly rapid fire. I think I have 27 slides, so we'll see if we can do it. These are my disclosures. So I want to focus on some ERAS Society guidelines for obstetrics and gynecology. This is the guideline, just to remind you that my friend and colleague Sean Dowdy and I started back in 2014, ultimately published in 2016. The original guidelines in 2 parts, now well over 70,000 downloads. Our team published the update to this in 2019, which again, quite a huge appetite. Just since March 2019, this has now been downloaded almost 90,000 times. We have about a monthly download of about 1,200, so people are still using it. So I'd encourage you to download it as well. We received some initial criticism that our guidelines were primarily focused on open abdominal and pelvic gynae surgery. So Alon Altman, one of my former fellows now in Winnipeg, he and I and kind of others did the vulvar and vaginal surgery guidelines. And then there's also been some reluctance to apply ERAS gynae guidelines to cytoreduction and HIPEC. So Martin Hubner and I co-led this particular team on HIPEC cytoreduction guidelines. This applies to both GYN and advanced GI surgeries. And the good news is that we're going to be starting to test these guidelines shortly amongst the centers represented here. Doug Wilson and I also co-led the cesarean delivery guidelines, and the update is that we're starting to begin the process of translating these guidelines into the ERAS interactive audit system, so probably coming out in the next year or so. This, of course, is one of the most common surgeries done worldwide, so it will be very important to get this up and running. And Doug and I have also started to look at doing ERAS fetal surgery. So this was just a paper we recently published on lower urinary tract obstruction surgery for the fetus, and to what extent would an ERAS guideline help with that. I think it's also important to look at other society guidelines. So Rebecca Stone from Johns Hopkins, she and her team wrote this excellent review on ERAS guidelines in minimally invasive gynecologic surgery. So if you want to get some recommendations there, that's a good one to look at. And also the Society for Obstetric and Anesthesia and Perinatology, primarily anesthesia-driven. Laurent Bolag from Seattle, he and his group put together this set of guidelines, which align quite well with the ERAS Society guidelines, a little bit more anesthesia-focused. So for the anesthesiologists in the room who do obstetrics, there's some additional information there that is quite useful. Christina Fotopoulou from London also looked at specific perioperative guidelines for advanced ovarian cancer surgery, and there's good alignment there as well with those. So just in the last couple of minutes, look at the outcomes for ERAS in obstetrics and gynecology. So we know that quite a strong retrospective evidence base from Sean Dowdy and his group, Pedro Ramirez at MD Anderson, and ours as well, showing reductions in length of stay, improved cost, and also complications and functional recovery. And then our own president-elect from ERAS Society, Kevin Elias, and his team. This is an extremely important study that showed that ERAS was the strongest predictor of return to intended oncology treatment with an odds ratio of over 10. Basically, patients on the ERAS pathway were able to get back to life-saving adjuvant treatment sooner than those who are not. Lots of people criticize the ERAS research, saying that it's retrospective. Fortunately, we do have new level 1 evidence in GYN. The Ferrari trial and the ProFast study both showed improvement. I know you like that. And we were also able to take data from that study. I collaborated with that team, and we were able to demonstrate a dose-response relationship for advanced ovarian cancer surgery. My colleague Steve Bish led the effort between our center, Mayo, and MD Anderson on this meta-analysis, basically showing that in almost 7,000 patients, basically ERAS is associated with improvement of length of stay, complications, reduction in readmission, no difference in mortality, and mean cost savings of over $2,000. So I think basically you should be doing it, but why are we not doing it? So Guido Bandori and I, Twitter-based surveys showed that many centers, especially LMIC centers, are not doing ERAS. So clearly we can do better. Unfortunately, there are lots of barriers in low and middle income countries, particularly financial and data collection challenges. But I will remind healthcare leaders and administrators in the room that ERAS is associated with improved cost savings, return on investment of 7.3. Finally, Pervez Sultan has recently performed this huge meta-analysis in cesarean delivery, showing that enhanced recovery after cesarean was associated with significantly improved outcomes with minimal morbidity. And I would encourage all of you, maybe some of you, to come to our gynecology symposium tomorrow, where we'll be talking about a lot of really exciting topics in our field. And also really excited, please stay tuned for the ERAS Society Handbook for Obstetrics and Gynecology that'll be coming out. And then please come to ERAS Society Congress in Madrid. We'll be hosting an OBGYN session there as well. Thank you very much.
Thanks, Greg. It's fascinating, the signal of ERAS compliance and cancer improvement. And when we did that for colorectal, the publication by Ulf Gustafsson showing the 5% impact downstream on cancer outcome, this would be a no-brainer, and everyone would be getting this drug if it was a drug that you could give. So it's fascinating. Next, we have Jenna Amory from Virginia Commonwealth University, who's going to give us the update on renal transplantation. Thanks, Jenna.
Hi, everyone. Well, I'm really excited to be an APP up at the podium. Thank you. My name is Jeanette Amory. As Dr. Scott told you all, I'm a nurse practitioner in the Division of Transplant Surgery at Virginia Commonwealth University Health System in Richmond. And I'm honored to present ERAS in renal transplantation to you today. I think, to my knowledge, this is the first time that renal transplant has made its way to the stage for the rapid fire session, so that's very exciting for me. I have no disclosures. So I'm going to briefly summarize the current status of renal transplantation in the US present the rationale for ERAS in this patient population, highlight some challenges, and describe current evidence, including the experience at VCU. So just some background, there's an extremely high prevalence of kidney disease and end-stage renal disease in the US, and the prevalence is rising. It has actually tripled over the past 30 years and is projected to further increase given population longevity and high rates of diabetes, hypertension, and obesity. So right now, well over 500,000 people live on long-term dialysis in the US, while another 250,000 people live with a functioning kidney transplant. Transplant is the treatment of choice for those with ESRD. Renal transplant recipients typically do live longer and enjoy a better quality of life compared to those on dialysis. And although there are many who continue to wait, we're actually performing more transplants each year, even through the pandemic. Kidneys are the most commonly transplanted organ. We do about 22 to 23,000 kidney transplants in the US each year. So compared to other surgical specialties, the field of transplantation has been slow to adopt ERAS protocols. There's an overall scarcity of published data for this patient population. This year, the ERAS Society did publish guidelines for liver transplantation, but we do not yet have guidelines for renal transplant. There are several reasons why ERAS should be applied, of course. We know ERAS has been successfully applied across numerous surgical specialties, and we know that ERAS serves to optimize conditions for patients, including those deemed high risk. ESRD patients are not straightforward surgical candidates. They're often frail. They have multiple comorbidities, including, as I said before, diabetes and hypertension, but also high rates of heart disease. And although there is a clear long-term mortality benefit compared to remaining on dialysis, the risk for perioperative mortality and morbidity within the first 3 months is very high. The way we manage these patients during the perioperative period, especially with regard to fluid management, is crucial to a successful outcome. So implementation of an ERAS pathway also decreases variability. Surveys of transplant centers highlight that there continues to be a high degree of variability from one transplant center to another as to how perioperative care is delivered. Guidelines tend to be very center-specific, and local practices can go unchallenged and unchanged for years. So when looking to apply ERAS to renal transplant, there are some unique challenges to consider. Unpredictable timing. The median wait time for a patient on the kidney transplant wait list is about 3.5 years. During this time, they're seen by their transplant team, typically a nephrologist, just annually for medical checkups. They can get called in for a transplant offer at any time, which makes prehabilitation and optimization efforts by the transplant team all the more challenging. In addition, transplants often take place at non-traditional hours at night and on the weekends, and we sometimes find support from anesthesia providers to administer regional anesthesia techniques such as tap blocks a bit limited. In addition, transplants often, multimodal pain management, we must avoid NSAIDs in this patient population due to the potential for nephrotoxicity, especially in combination with the nephrotoxic calcineurin inhibitors that we use for immunosuppression. And transplant recipients are advised to avoid these NSAIDs for life. Fluctuating fluid balance, particularly challenging in this patient population. The aim is for a positive fluid balance at the time of reperfusion to ensure adequate renal function. But we do run the risk of subsequent volume overload. Timing of dialysis and the variable post-operative urine output also must be considered. Lines and drains. IJ central lines typically are placed to allow for central administration of induction immunosuppression. Foley catheters and ureteral stents protect the integrity of the new ureterovesical anastomosis. And although controversial, many surgeons routinely place a JP drain. The presence of these lines and drains we know can work against us in our attempts for pain management and early mobility. So there are just a very small number of published single-center cohort studies comparing an ERAS protocol to traditional perioperative care of renal transplant recipients. The best evidence that we have is a systematic review and meta-analysis published early this year from Imperial College London. The authors included 10 studies, several of which focus primarily on the use of ureteral stents and optimal timing for removal. Key findings are overall very positive. Lower incidence of urological complications, no difference in rates of rejection or delayed graft function, decreased length of stay with no increase in readmissions, and no difference in survival rates. So in 2019, at VCU, we implemented a successful ERAS protocol tailored to this specific patient population. All aspects of a comprehensive ERAS pathway were considered, spanning the continuum of care, including ERAS education, setting expectations, limiting fasting, expanding nausea prophylaxis, limiting opioids, optimizing intraoperative fluid management, guided by non-invasive cardiac output monitoring, mobilizing patients sooner, and removing these lines, these drains, these stents earlier whenever possible. Some findings. So post-ERAS implementation, we did see less intraoperative IV fluid use, and despite some concerns that this could negatively affect early graft function, it was actually not the case. Rates of delayed graft function were actually lower in the ERAS cohort. Opioid utilization post-ERAS implementation was drastically decreased. Perhaps the most phenomenal of findings here, with no difference really in the overall pain scores. We've also seen less post-op nausea and vomiting and less time on supplemental oxygen. We decreased length of stay without an increase in readmissions. So the literature and our experience at VCU is very encouraging. It is evident that ERAS can be applied safely and with the same positive outcomes demonstrated in other surgical subspecialties. As mentioned, there are several special considerations for this patient population, and it's still early days for ERAS and transplantation. Further studies are necessary to provide higher level evidence, but it is clear we can start to incorporate ERAS, implementing guidelines based on the best available evidence and expert consensus, and decrease variability by standardizing care to improve patient outcomes and power future research efforts. My references and my contact information. Thank you so much for the opportunity.
Thanks, Jeanette. You can see she's done a huge amount of work and did a whole thesis on this. And I would actually request for, if you've got any other centres that are doing ERAS and renal transplant, can you sort of put them in contact with the society, because we need to get that guideline together. And also I'd like to give Jeanette credit, because in the ERAS Society book, as you know, we've got a time-based diagram with all the different elements, and it's Jeanette that developed that for us. So thanks, Jeanette. That's a big impact for everyone. So I don't know if it's last, but no means least. I don't think so, because we've got Drew as well for paediatrics. So I'd like to welcome to the stage Carol Peden, who's going to give the update on ERAS and emergency laparotomy.
Thank you, Mike. And following on from the last great talk, my talk is entitled Emergency General Surgery in the program. And I'd just like to give you some idea of what we're talking about here. US epidemiological data shows emergency general surgery comprises 11% of all surgical cases and 47% of surgical deaths. So when we're talking about enhanced recovery, in this patient group, we're not talking about primarily reducing length of stay, we're talking about reducing mortality. And just if we talk about emergency laparotomy, non-vascular, non-trauma, primarily 50% of it is emergency colorectal. When we started to get large-scale data, which was as late as 2012, in the US, the 30-day mortality was 14% from NSCIP. And in the UK, at about the same time, it was also 14%. If you get into the elderly, and a large number of these patients are elderly, it's at least 25% in the over 80s, and the NSCIP data shows over 90%, perhaps unsurprisingly, in over 90s. So we're talking about really big mortality here and a chance to make an impact. So these are the guidelines which have been a long time coming. I've been thinking about this work for a very long time. Myself and Mike, your name's cut off. Mike is the final author on this and somehow got cut off. Anyway, they were published earlier this year. And this is part one, because this is complex. There's a lot of underlying conditions that can have emergency laparotomies. So we decided to focus on the early phase, so preoperative diagnosis, rapid assessment, and optimization. They're open access, so again, they've been downloaded. We've had people contact us from all over the world, so please go and have a look at these. And any studies I mention in this talk are included in that paper. So really, enhanced recovery, remember, we have this focus on getting the patient in the best possible condition for surgery. But in the emergency laparotomy patient, many of them are presenting in a state of acute physiological derangement. So the insult is already happening. So we have to rapidly optimize them. So we have to compress that time prior to surgery. And in fact, we should generally not delay surgery. So optimization might have to be going on while we actually start to operate. So there's multiple small studies that inform our evidence that this reduces mortality. A couple of my own studies. This was a small, basically pilot study from 4 hospitals which showed a significant reduction in mortality when we took an ERAS approach. And when we then scaled that up, 5,000 patients pre and 9,000 post-ERAS implementation in the UK, and we showed a mortality reduction to 8.7% and a reduction in length of stay. So that was published in, as you can see, JAMA Surgery. But all these small studies show a clear signal in reduction in mortality. So the guidelines are international. USA, Europe, Australasia, South America. We had general surgeons, emergency surgeons, anesthesiologists, geriatricians, and we went up to July 2020 with a grade and approach in Delphi. And as I say, we are hoping to get part 2 done by the end of the year. We've sort of been delayed by COVID, just like everybody. You've seen this before, but the real focus on this first area, and you can see a lot more goes on here, because you've got to think about sepsis, you've got to think about fluid resuscitation, you've got to do shared decision-making with very elderly, frail patients and their families about what is the right thing for them and their goals. So again, that's why we focused on just doing part 1 initially. And the things we list, there are 12 components: early identification of physiological derangement and intervention, screen and monitoring for sepsis. A lot of these patients are septic or have low-grade sepsis going on. If you have full sepsis and you're over 65, the impact on mortality is really significant. Early imaging, source control, and again, that risk assessment to aid consideration of the pathway of care, i.e. do you need ICU afterwards? And most of these patients should. So again, I just put the clocks, this focus on urgency, screening for sepsis, timing to get to surgery. And those references down there below give you an idea, if you want to read them, they show you the impact of sepsis on these patients. Other things we talked about: fluid and electrolytes, anticoagulants and antiplatelet drug correction, VTE, analgesia, NG tubes on a case-by-case basis, and no evidence for carbohydrate loading in this patient group. This is the first ERAS guidelines with a real focus on the elderly because of the number of patients, and we've included brain health, delirium screening, shared decision-making, and frailty up front, because we wanted to draw people's attention. Even if you can't do it in the preoperative period, we want you to start thinking about it. And there's clear evidence from Rachel Cadarou in her work in Canada that this reduces mortality. Thinking about geriatric assessment early and being proactive about it reduces mortality and length of stay. So part 2 coming very, very soon. We're having a meeting after this to talk about it. And the importance of postoperative pulmonary complications. These patients have a very high incidence of aspiration and pneumonia postoperatively, failure to rescue. Again, a domino effect. If you get one complication, you get multiple others. The need for ICU for most of these patients, ongoing comprehensive geriatric assessment, Some of these patients may not benefit from surgery, so the concept of end-of-life care and no laparotomy, and we will include quality improvement and system organization. So keep your eyes peeled, but in the meantime, go and download the first part. So thank you very much.
Great, thanks, Carol. You can see how complex that guideline's been: frailty, delirium, system management, a whole complete new concept of writing guidelines, really. Last but no means least, it's Drew Franklin, so giving us an update on pediatrics. So thank you, Drew.
All right, thanks, Mike. Well, I have the honor and privilege of serving as your final barrier to either the ultrasound workshop or the Sazerac bar, whatever you choose. So we spent 2 hours talking about pediatrics this morning, so this will truly be rapid fire here. As far as pediatric ERAS goes, what do we have so far? So where did we get started? We got started in 2018, where we actually started as our own sort of subspecialty organization, where we had our own leadership structure, and we looked to really try to go independently. And then when we kind of reconvened, we decided to kind of become a subspecialty component of ERAS USA, and Mike and everyone else within ERAS USA has been very kind and welcoming and bringing us on board here. We have active multi-institutional studies that I'm going to go over here in just a little bit: our pediatric colorectal surgery, our pediatric urologic surgery, and then neonatal general surgery as well. As far as the medical evidence, I know we talked a little bit about this morning. By far and away, the most evidence that we have for neonatal and pediatric ERAS is for gastrointestinal surgery. There's also a lot of work being done in urologic surgery, and so I'm going to highlight that. There is a growing body of literature in neonatal GI surgery done by Mary Brindle, who unfortunately could not be here with us today in Calgary. And then the last kind of most robust piece of medical evidence is for spine surgery, scoliosis surgery, particularly idiopathic scoliosis surgery for our otherwise healthy kind of 12 to 16, 18-year-old young women and men. There's also a paper that we wrote on hip surgery. There's some emerging evidence for gynecologic surgery in adolescent and teenage girls, cardiac surgery. A lot of this is sort of ERAS light, I would say. They don't quite meet all the 21 criteria. As you can imagine, a child with hypoplastic left heart syndrome has a lot of barriers to meeting a lot of those 21, 27 criteria for ERAS. Pectus excavatum, there's a good paper out for that, and we're about to publish our data as well. And then there's some evidence for bariatric surgery. So that kind of rounds out what we have from an evidence standpoint. If you guys haven't heard from Dr. Rove this morning, the biggest thing that's going on right now in pediatric urology is the PURSUE trial that he has really launched and has done an amazing job in the past several years with growing pediatric ERAS in urology. It is a multi-center study, and what Dr. Rove is doing is it's a multi-center prospective case control study where he's got the prospective arm, which will be the ERAS arm, and then he's got historical controls at all of the centers that we showed in that previous slide there. And his primary outcome is going to be the number of ERAS items that are achieved per patient. As we all know, it's important to meet those individual elements because they do have very positive synergy when used together as opposed to their individual elements. The secondary outcomes that Dr. Rose is going to look at: length of stay, complications, ED visits, readmissions, reoperations, pain scores, and opioid use. And so hopefully we'll have some information on that in the next 12 to 16 months, and that will be a very powerful paper for us overall in pediatric ERAS. Dr. Raval, who you guys heard from this morning as well, just a quick update on what he's doing. He is in the PI for the ENRICH US study, which is enhanced recovery in children undergoing surgery. It's also a very large multi-center trial involving 18 pediatric hospitals, and he does have a pretty significant NIH funding for that. He's enrolled over 270 patients as of this month. His goal is to get to about 1,200 patients before he publishes his results. I do want you guys to focus in and maybe take a snapshot of this website. And so if you are at an institution where you're you're thinking about starting pediatric ERAS, I would say that Dr. Raval has the most comprehensive information on his website. He's got some fabulous YouTube videos for both healthcare providers as well as patients and patient families, anything from mindfulness, deep breathing exercises that children can do during their recovery phase, as well as ways to explain ERAS to children at various ages as well as their family members. And so all of these are publicly available. They're on YouTube, and he and his group have been very generous to share this great body of work with the rest of the world. Feel free to email me if you have any questions. My email address is up there. Join us. We're a fledgling society. We're growing. We're looking to add more institutions. Things that we have planned for the next year is continuing to have this multi-institutional collaboration between a few of the centers that have shown some interest in pediatric ERAS. And then, Dr. Rove and I are going to work on hosting some webinars, starting with his institution in Colorado, Children's Hospital Colorado, where they're going to say, this is how we do pediatric ERAS, and we're going to work through ERAS USA to host these webinars, and so you can look for information when we get some final details on that, and we'll probably do one at Vanderbilt, maybe Lurie Children's in Chicago, and maybe a couple other centers in the country that do ERAS very well in the pediatric population. We're working on developing some of these ERAS Society guidelines. We continue to give lectures across the country, component society lectures, and that's what we're trying to hit, as well as all of our pediatric subspecialty organizations, and talk to them about ERAS as well. So thank you for your time. Thank you, Mike.
Thanks, Drew. So I think when I opened the Congress, I said it's been a difficult 2 years for everyone, but I think this session here has really given an overview that people have done a huge amount, even in the last 2 years, and the depth and breadth of what we're doing as a society, from pediatrics, spine, emergency laparotomy, as well as all the other specialties, is really outstanding. So it's still an exciting time, and I'm really pleased that this meeting today has really been reinvigorated everyone's energy. So I'd like to bring this session to a close. I don't know if anyone's got any questions for me or for any of the society members on the board here. Has anyone got any questions about any of the divisions or anything like that they want to field? Greg?
We recently published a study of our kind of all health system multi-pathway experience with ERAS. And the great news is that in a number of the pathways we showed clinical outcome improvements, but sadly in 500 Whipple's patients we showed that ERAS implementation, which was not that great of implementation because our teams only hit a compliance of 66%. They increased by 25, but could not get above 70. And admittedly, they were following the 2012 guidelines only. So I guess the question for you is, we talked about getting above 70, and you also talked about some major changes in the 2019 guidelines. Should we be really driving towards getting up to 75 and also trying to follow the 2019s more closely? Can you give us some advice on how we can, because in fact length of stay increased almost 3 days with ERAS, so.
Thank you, Greg, for this question. I need to have a little bit more information so as to be able to say what I think about it. Let me start by saying that how many hospitals are doing the Whipples? It's only one. So that would have been two big hospitals. How many Whipples do they do per year? Well, about? Yeah, so maybe 50. Yeah, so that is a relatively low volume hospital for Whipples, and it starts from there. If you go, if you go even in the early 2000s by the published evidence, back then there is a lot of information that shows that volume does matter, especially for complex surgeries like Whipples and esophagectomies. And if you have a hospital that the average length of stay it's about 12 to 14 days. The first thing that you see is how many do they do. If they do 30 or 40 patients a year, the reason why you cannot drive your length of stay lower is not because you do not apply ERAS principles well. It's because the system, the hospital itself, all the teams, not only the surgeon, all the teams, they do not have enough volume so as to be experts into that. I would say this is where I would start. The second thing is that you do not need to target, at least I know for sure this is true for Whipples and major hepatectomies, you do not need to target all 27 parameters. There are a few parameters that they are actually have more gravity, like the mobilization, the early post-operative nutrition, and if you have limited resource, ideally you should do everything, but the truth of the matter is that you have limited resources. So you need to target the parameters that they are important. If I had a program that does about 100 Whipples a year, and still I cannot achieve the outcomes that I would like, and I detect that I have problems with the ERAS implementation, first I would target mobilization. The resource, I would take it towards hiring more nurses to get better.
Thank you very much.
Okay, I'm talking too much, I think. Huh?
That's all right. So next, everyone, we got the most phenomenal session next. We've got Jeff Gaston, who's one of the most amazing lecturers and educators that I've worked with. And he's leading the Passera workshop, which is absolutely amazing. You've got to go and see it because you can look at blocks and even do them in 3D and everything. It's not for physicians or anesthetists, it's for everyone. And I encourage everyone to go to this session because if you understand the way that we are doing analgesia for our patients with these blocks, then you can understand the recovery better. And then we can work better as a team. So please, I think there's obviously a limited number, but I think there's still a few places free. So if you all go, those of you that have already signed up, please obviously go. But I encourage everyone to try and attend that session because it's absolutely amazing. Thank you very much. And we're back here tomorrow for another breakfast session at 7. Thank you.